Okay, thank you, Andy. I think we'll get started. I have 8:02, and looks like we have most of the usual suspects here. So thanks for joining us here on February 5th, the second session of the new year. Next slide, please. So this is our usual information about cardio. I'm not going to go over it in detail. Next slide. Today, I'm up, I think, for most of the session. We'll talk about patient-driven QI, a clinical pearl that I think will be useful, and a brief case study, as well as Amanda will lead the report outs, and we'll wrap up. Next slide. These are our sites, which you're familiar with. Next slide. And this is our team. Next slide, please. And no disclosures related to this. Next slide. And you can get CME credit. I hope you're all claiming it. It has to be claimed by May 5th. Next slide, please. And you can get MOC credit if you are board certified by the ABFM as well. Next slide. Remember, no PHI in your discussions of your projects. Next slide. And we are going to get started. So today, I think, is quite timely because the whole landscape of how we improve quality of care is changing rapidly. You've probably all heard the term shared decision making, which is a discussion between a clinician and a patient about their choices, etc. It's not really what we're talking about, though it's related today. I'm going to get more specific in a moment. Next slide. So today, I'd like you to be able to define and discuss patient empowerment as a strategy to drive QI, telemedicine as a tool to engage patients, and I want you to be able to know what persuasive design is as it applies to patient health technology tools, which are often described as empowering and useful tools for QI, but we'll talk about the limitations and special considerations of those tools in a moment. Next slide. So what is patient-driven? If a patient comes to see you, let's say it's a regular checkup for type 2 diabetes, and you ask them specific questions about their care or their symptoms, that's not really patient-driven. Or let's say you reorganize your office to facilitate point-of-care hemoglobin A1C testing, and you're saying, well, I'm being more patient-centered now, they don't have to go to the lab. That's not patient-driven either. So let's talk about what it is. So patient satisfaction measures, we are probably all exposed to. I certainly am here at university hospitals. So my patients see me, and every month I get different satisfaction measures. Something called STATIT, which is a QI type of measure. Also just general patient satisfaction from Press Ganey reports, whether they were happy or not with my care. And you can argue that because these are completed by patients, patients are driving improvement in the quality of care. That is not necessarily the case because they are passive participants. That is not patient-driven QI. Now, if we go up to the next level, there are patient-reported outcomes and patient-reported experience measures. So, for example, these have to be worded quite correctly. If you ask somebody, well, are you feeling better? Are your symptoms improved? Is your hip pain improved? And that's a patient-driven measure that goes into your QI project. That is a patient-reported outcome. Still not patient-driven because the patient is not driving QI improvement. You might be treating a patient with hip pain, put them on NSAID, send them to physical therapy, and the patient says, I am no better at all. Well, how did the patient participate in that plan? They did not. At the next level, you have patient-reported experience measures, and this is not their outcomes necessarily, but it's how they experienced care. So this is much more patient-centered. So here's one example. We'll talk about more later on in the talk. So side effects of medication are explained to a patient. So did your doctor explain side effects of the medication to you? A lot of patients will say, yeah, I think he did or she did. But that's not the same thing as the doctor explained side effects to me in a way I could understand. So that's more of an experience measure as well. Still not patient-driven because the patient isn't driving what the doctor does. That is the key. The patient is driving what the health system, what the staff, and the clinicians do. That's what patient-driven is. Now, the next level, of course, we've heard of many of these. Many of you are, well, many of us are involved in research. We all have a stakeholder advisory panel. I mean, cardio probably has I'm sure has an advisory panel made up of patients, committees. They weigh in on different projects, different aspects of care. That is not patient driven. The reason is they're not functioning as patients there. They're functioning as either investigators or those who have experience to contribute. They're not driving the improvement for patients as a whole. So now let's talk about what patient-driven QI really is. And we'll start with the concept of empowerment, which I know I've spoken about over the last several years here in the ECHO series. Next slide. So empowerment, the sort of official definition, which I find very difficult to understand sometimes, it's like comes from the psychology literature, is defined as a means to promote autonomous self-regulation so that the individual's potential for health and wellness is maximized. So first of all, they're trying to maximize their health and wellness, but they're doing it autonomously and in various ways. Next slide. This is the European Patient Empowerment Charter. It's been around for 10 years, where in Europe they are far advanced in empowering patients. But these are the core principles that outline it. I'm more than my health condition. I'm empowered to the extent I wish to be, which is one of the most important things. Yeah, I'm an equal partner. I have the information I need. My healthcare professionals in my system promote health literacy. I have support. My experience is a vital measure. I can participate in evaluating co-designing health services so they work better for everyone. So that's patient-driven. Through patient organizations, my voice becomes bigger. Equity, empowerment go hand in hand. I want a fair deal for all patients. So empowerment is highly aligned with the concept of patient-driven QI. I just want to stop there and see if everybody understands that distinction. Okay, so a patient satisfaction measure is not patient-driven. Unless the patient is participating in improving quality of care, you do not have patient-driven QI. Any questions? Okay, glad we're on the same page. Next slide. So let's talk about satisfaction and care and speaking up and why this happens and how we implement patient-driven quality of care. So a lot of our patients, our Medicaid patients in Ohio are Black adults, African Americans. And what struck me about this Pew Research Center survey, Pew is a very reliable survey purveyor, is that so there's not a lot of difference between how satisfied or how high quality people think care is between Black adults, men, women, income levels. And if you look at on the right-hand column of the slide here, you'll see that all U.S. adults, if anything, Black adults are actually more satisfied with care. But there are, of course, for everybody, there are huge opportunities for improvement. Why I showed this slide is I think that it says they've had to speak up to get proper medical care. When a patient speaks up and says, and they do to me all the time and say, oh, you forgot to refill this, or, well, you didn't explain to me when I'm supposed to come back again, because sometimes I forget, or the nurse didn't come by and do something. That is an empowered patient. That is a patient that is driving improvement in care quality. Next slide. So some time ago, I think about 5-6 years ago, I know we have a lot of projects called Empower, the co-PI of an Empower R01 that has wrapped up now. It has nothing to do with cardiovascular risk. We also created something called the Empower Diabetes Checklist. This project was not actually funded, but this checklist is still around. And the idea behind this checklist is to empower patients so that they, I won't say demand, but they feel empowered to seek the highest quality of care. So how you might use a checklist like this is fairly simple. So somebody is coming in for their diabetes checkup. I guarantee sending this in advance of a visit by mail, by email, by text is not really the best mechanism. They're sitting in the waiting room, and the check-in person says something. In fact, Dr. Rao would like you to finish this checklist before you see him, because it will help him provide you with higher quality care. Oh, and it's pretty easy, right? So think about some of these things. Did your doctor check and discuss your cholesterol within the past year? Number 5. Okay. So a patient comes in and says, no, you didn't. And then they say, oh, actually, I did check it. Let's go over the result with you. And you can see the result was normal, which is why I didn't alert you to the result, for example. But that's empowerment of the patient. The patient now has useful information that they did not have before. So it's not that they are activated to some extent, but they are actually requesting higher quality of care, right? An activated patient is someone saying, hey, I really don't want to get influenza this year. Geez, I really, I want to get the flu shot. That's activated, but administering that flu shot, making sure they get it on time, etc., is an empowered patient, and that's patient-driven quality improvement. So this is something you would probably um, um, distribute in advance. Now, the question number 11, I think, is one of the most important things. It was actually from Kurt Stange's. Kurt Stange was the one who contributed that from here at Case. Does your doctor know who the most important people in your life are? Imagine, you get this as a clinician, as a physician, and the answer is no on it. And then you start to think, well, actually, I don't know. You're probably going to ask that person, and they're going to say, well, it's probably my son if it's an elderly patient, and he comes out to look after me once or twice a week, but he's got a family of his own and is busy. You're getting huge amounts of valuable information. And in that sense, the patient is driving improvement in the quality of care as well. Okay, next slide. So, how do we empower a patient? So I said there are many tools that will help patients to become empowered to seek quality of care. Well, first of all, here are some general tips. So this is language that is extremely useful that I try to use. Of course, sometimes I forget, like everyone else. So always say, what questions do you have about your visit today? Instead of, do you have any questions about your visit? What do you think the response is half the time or 60% of the time? No, I'm good. No, see you in 3 months. That is polite. It's intended to make us feel good, but it's very different than saying, I'd like to know what questions you have about your visit today. I'd like to know if I can answer some questions. What can I do to help you to make this happen? Here's another one. What do you believe you need to better manage your diabetes? Great question versus here's what you need to do to better manage, which is, of course, paternalistic and not patient-centered. How can I help you achieve your goals? Great question. You need to be more consistent in taking your medication is not the way to say things. Closing a visit with, let me summarize what we've talked about. Okay, here's what we're going to do. You're going to go get your x-ray. You're going to go down to the lab after this. I'm going to see you in 3 months. You're going to talk to the nutritionist in between. That's my summary of it. Do you have any questions or concerns about that plan? So you are actually requesting the patient to drive quality improvement, to drive factors within the visit that are important for their chronic condition. Next slide. Now, what can patients to do to be empowered? These are the National Institute of Aging recommendations. Many of our patients, let's face it, in Medicaid QI are not over the age of 65, but we do care for a huge proportion of these patients as well that are older Americans. And decide what questions are most important to ask the doctor in advance. Stay focused on when you're there. In my experience, that's the one that's the most difficult. On Monday, Tuesday, when I was seeing patients, one lady talked about the trouble with her landlord and heating during the recent cold spell. This went on for 5 minutes. And I know our residents and people that are much younger will just continue to listen and hope that useful information comes out. Let me tell you that you can empower patients not by simply listening, though listening is important, but you can stop and say, I'm really sorry to hear about the difficulties in your apartment and with the heating, but I'd like to focus on your heart failure right now. And we can get back to this other issue if you like. There's nothing wrong in saying that. So make sure the patients stay focused and help them to stay focused. Be honest and open, of course, share your point of view. And remember that physicians may not have all your questions. Now, these are just general recommendations for the public. And if some of you are highly literate patients, go to the National Institute of Aging website and look at these. They may incorporate them into their visits. Next slide. Boy, is that easier said than done, right? So low income and minority patients are challenged by health literacy. We have no idea. Okay. We do it all the time. I've been practicing since 1996. A few weeks ago, a patient of mine and his wife came in, and they had an insulin pen needle with them, and they hadn't been using it. He was the diabetic. He hadn't been using it. He said, "I'm not sure how to use it." So I said, "Let me see if I can help you." And I saw him, and I said, "You need to turn this counterclockwise." I said, "No, no, no, counterclockwise." I said it 3 times, counterclockwise. And then I realized he did not know what counterclockwise versus clockwise is. Okay. So, like most people, we consistently overestimate health literacy. We all belong to the upper middle class. It's unimaginable that we would not know that. In the city of South Side of Chicago, the average patient who arrives by bus, if they know what time a bus is to arrive, and if they know what time it is now, 2/3 cannot figure out how many minutes or how long they would have to wait. So this is the level of health literacy that we're often dealing with our patients. Most health literacy, however, focuses upon readability. 58.4% of American adults, and I know this is really shocking, read at a 6th grade level or lower. And so a lot of patient education materials are designed, and we have brochures and pamphlets. Who reads those brochures? Not people with a 6th grade level of education, people with a much higher level of education. So there's little focus upon motivation, for example, to read this. So for someone to understand a patient education pamphlet that has a low level of health literacy, yes, they can do it. It may be designed for them, but it's a lot harder than it is for us. And therefore, they're not going to do it. So let's keep a lot of these things done. So you can empower patients, but it's extremely challenging for many of them. Now, there is a way to think about who an empowered patient is. The portals, which I know most of us are on Epic. I don't know, some of you are not, perhaps, but I think it looks like I know, Austin, you're not on Epic, but a lot of you are on Epic, but most EHRs have a portal. So portal use is somewhat of a proxy for the empowered patient. So a patient who sends you messages through the portal, gets refilled, sets their appointments online, generally someone who's very health conscious and can self-manage their chronic illness quite well. But there are huge differences. Age is the big one. And I'll talk about that in a moment. Once people hit about age 70 or 75, and you think about our patients, that's a huge proportion of them. Portal use declines substantially. I had a patient who said she doesn't like using it. She doesn't want to use it. She's signed up and everything, and there's a certain apprehension about it. Of course, higher income people, younger people are more skilled with it, but age is the biggest thing. Ethnicity is not such a, race and ethnicity are not such big factors. Next slide. So access does not bridge divide. So Walker, I think some of you may know him from Ohio State, who studies these things. So I did a study of portal use, and the bottom line was the findings suggest that the availability of technology alone may be insufficient to overcome barriers to use, and that additional intervention may be needed to close the digital divide. And this is a huge challenge because people think just by making technology available, because it's cool and it's efficient, people are going to use it, they're going to be empowered, and their health is going to improve. So if you get a message like this is a real message. It says, "Hello, doctor. I wanted to tell you that I've been experiencing some diarrhea since I started the medication. I didn't expect this, and I'm looking for your advice on how best to proceed." I read a message like that, I already instantly know this is a highly educated patient, okay? Just by the language, the structure, etc. How many of our Medicaid patients, older low-income patients, are able to type out a message like that in the portal and send it to me? Very, very few. So keep that in mind. So voice is critical. Auditory sort of interaction is critical, and we'll talk about that in a moment. Next slide. So we've studied Kelsey Alfeld, some of you met, is my mentee, one of my mentees, and studies trying to overcome the digital divide for older African Americans with type 2 diabetes. And it was fascinating over the last couple of years. We've seen this line of inquiry expand. Essentially, the biggest barrier, first of all, young people of all races and ethnicities are extremely savvy with smartphones and apps and stuff. And you can imagine that this is true. As soon as people get older, they are much less savvy. And beyond age 75, they generally will not use telemedicine or portals or that sort of thing. What she did show is fear is one of the biggest things. They all have smartphones. 95% of older African Americans have smartphones, which they use regularly for shopping, texting, and of course, phone calls. But when it comes to other applications, there's a significant amount of apprehension, largely because they don't feel confident that they have the skills to do this. So we just published a paper on training members of this population on how to use telemedicine, and the training works, and they do set up telemedicine appointments, and they are able to take advantage of this very well. That's going to be expanded. She is submitting an R01 grant in that area going forward. So keep that in mind as well. That's another way to empower patients through telemedicine. Next slide. Okay, so I want to talk about some personal experiences with health information technology research over the last 20 years or whatever it's been before we wrap up. So there is a healthcare technology incubator at the University of Chicago called Matter. And I've been a judge for Matter for a long, long time. And people come to Matter to present their ideas for new health information technologies that they believe will improve the quality of care. And these are often very well-meaning people. Most do not have a clinical background. They're technical people. And I remember it was a very long day because it's like a Shark Tank type of thing you go through, and everyone has 15 minutes, and you don't get many breaks because everyone wants to present because there's funding involved for these things. So I remember this young woman who had something called a heart failure tracker. Tracks your salt intake. I mean, who tracks their salt intake really? But it tracks your salt intake, tracks your weight and your medication use. And I said this exactly. Yes, that's exactly what my 80-year-old patients with heart failure are saying. You know, I could only better manage my illness if I had an app on my smartphone, which I can't even see the letters very well. So it's often, if we can get to the next slide, it's technology in search of a problem to solve. So I've been on the health information technology research study section, actually with Elise for a number of years. It is suspended, but I am the incoming chair of the study section as well. And one of the two questions that one of the questions that comes up all the time in these applications is, do you have any evidence that, because so many of them are technology in search of a problem, do you have any evidence that the people in greatest need will actually use your technology? And the answer in these proposals is often no. So mobile health apps are more likely to be used by younger, more affluent, and more educated people. The majority of Americans do use them or have used them, but that doesn't mean they use them regularly. So we're going to talk about how we can empower people with mobile health apps in a moment. Next slide. So what does a mobile health app do? Now, the simple worksheet on empowering people with diabetes is probably pretty good, but technology is advancing. We talk about AI, we talk about remote monitoring, et cetera. And to some extent, patients can drive QI through these mechanisms. So mobile health apps have three primary purposes: staying well. Some of you count the number of steps that you're taking per day. Okay, that's a pretty high functioning person. Oh, I'm up to 10,500 steps. A lot of our patients do not count steps. Okay. Optimizing performance. I don't think anyone, I'm certainly not in this category. So these are athletes who are trying to optimize whatever it is, their VO2 max or something like that. That is less than 1% of all mobile app users. And of course, they're very young and fit. The majority of our patients want to get healthier. That's the purpose of using these. Next slide. So how do you get someone to be empowered to use an application? For example, how do you get someone to bring in on their smartphone their blood pressure readings every morning for the past 7 days and show it to you and say, how do you think I'm doing, doctor? How do you get to that point? Well, you don't send them a portal message saying, hey, check your blood pressure every day. They're not going to do it. You have to use something called persuasive design, which is an emerging concept. And we have very little time to talk about it, but there are critical components to any application. One is primary task support, reducing and tunneling, which means getting to the issue on hand. First, take the cuff, unwrap the cuff, put it on your arm. Make sure that it's very, very specific in terms of instructions. Credibility, if it's coming from you or from a credible source, it's more likely to be used. Dialogue support means the app has to give the person feedback, preferably by voice, about how they're doing, praise, rewards, etc. Social support, that means peers, and normative influence is hugely important, especially for men, by the way. They're much more competitive. They want to see how they're doing in terms of weight loss and cardiovascular risk, etc. So comparisons, tips, etc. is very, very important. So these are the components of persuasive design. Unfortunately, a lot of these mobile app developers, even people who develop them for EHRs, etc., they just want to sell their app to some system or to patients, and they're not worried about whether it's used or it improves health. Next slide. So we did create, as part of our medical weight loss and cardiovascular risk reduction program, this is not a commercial product at this time, but it's called My Weight Loss Ally, which uses artificial intelligence to encourage patients to stick to some basic goals. We put a lot of work into it. So you start by selecting an AI coach who either looks like you or someone you aspire to be, and you can try it out. And Andy, next slide. So Andy kindly created a QR code, and you can actually try out an intake on it. A lot of people find it fun. You cannot use the full thing because it's part of a research program, and it's only for specific patients right now. But I do encourage you to try it out. The reason I want you to try it out is it's a way to empower patients through persuasive design, and we'll give you an idea of what apps of the future might look like several years down the road. Next slide. Okay, I'm going to stop there right on time, see if there's any questions. Okay. Andy, if there's no questions, we can move on. So this clinical pearl is going to be probably not too controversial, but I'm curious as to what people do. So this deals with low dose aspirin for primary prevention of cardiovascular disease. I'm on the USPSTF, and I was not engaged in formulating this recommendation, which precedes me, but it's a C-level recommendation, which means that it's kind of a shared decision-making selective recommendation. There is a small benefit to low-dose aspirin, 75 milligrams or 100 milligrams daily, among patients ages 40 to 59 who have a 10% or higher risk of cardiovascular event in 10 years. So you might use the PREVENT calculator, the newer calculator, punch in their risk factors. And if it's above 10%, they may get a small benefit. If they are in this age group, it's not recommended for patients 60 and older. So I'm in the age group that has the small benefit personally, and I do not take low dose aspirin, just to give you an idea. I don't know what people are doing. My impression is this isn't something that comes up in a lot of clinical discussions, but I don't bring it up too often. But patients themselves are taking low dose aspirin because they've heard good things about it. Let's just, before I ask you guys what you guys are recommending, let me make a few points. Yes, you can go into the PREVENT calculator and calculate your 10-year cardiovascular risk or admission risk for heart failure. More likely than that, it's like taking a multivitamin when you smoke 2 packs per day. Most of our patients who we look after who have cardiovascular risk have other things that are more important to manage. Their blood pressure, their diabetes, their lipids, their weight, all of those things, or even their mental health is probably a higher priority them being religious about taking this aspirin daily. That's my personal feeling about it as a C-level recommendation. I do sometimes have these discussions with patients, but for the most part, it's a patient-driven sort of thing. Definitely not recommended for patients 60 and older because the risk of bleeding exceeds the cardiovascular benefit. Then there is the issue of secondary prevention, which is completely different. And so a secondary prevention is someone who's had a cardiovascular event, and they should definitely be on aspirin. There is a product called Yosprala, which has been around for about 10 years, which combines aspirin and omeprazole, and is safe and effective and has been shown to have some benefit. But we're talking about primary prevention. This is a very cheap intervention as well. So let me stop there and see what people are doing with respect to low-dose aspirin. Any thoughts?
Goutham, this is Bhaskar.
Yeah, go ahead.
I actually used to recommend low-dose aspirin to the younger age group that we are talking about, 40 to 59. I don't do this anymore.
Mm-hmm.
And based on so much conflicting data around, and actually, a tablet of aspirin knocks out all those receptors forever. It is a permanent blockage. So,
Mm-hmm.
technically speaking, they could be taking it twice a week or 3 times a week and get the same benefit.
Yeah.
But I don't recommend anymore. But of course, secondary prevention, yes. Every patient for
Mm-hmm.
secondary prevention, yes.
Yeah, thank you, Bhaskar. I think I'm almost exactly on the same page. I don't go out of my way to recommend it for a couple of reasons that you mentioned. One is that their other risks are almost certainly overwhelming whatever benefit they get from aspirin. Let's say it's a relatively healthy person, but he or she has a spouse who smokes a couple of packs per day, right? That's probably a higher priority. So focusing on aspirin is less important there. The benefit is relatively small. As you said, the overall data is a little bit conflicting. There are much higher priorities. Okay. Next slide, please. So we'll talk a couple minutes about the case discussion, and then I need to turn things over to Amanda. So this is Jose Tavares. He's a lead physician at a 12-provider primary care practice near Akron. He wants to encourage patients with hypertension to self-monitor their BP. So very timely. We want to empower patients to manage their blood pressure to promote engagement and hypertension control. How would you start that discussion with an individual patient? Who's never done this before, never done any home monitoring.
This is Arpita.
Yeah, go ahead.
So, this is a new onset hypertension patient, from what I understand, right?
Yeah, sure.
Okay. So, first we need to see the literature, like like literacy, to see if how much they actually knew about high blood pressure and how it affects, and depends on their work-life balance. If they are like shift workers, we need to see what time they can take the medication and what's the right time to take the blood pressure readings, and how to actually use the cuff, and how to actually know if they're doing it correctly, and we can help them to initially schedule a nurse visit to bring their machine, and the nurse can correlate that with our machine and see like if it's working good and the patient is doing in the right way, and that we can print out a log sheet where they can have like a date and time for the blood pressure reading, and trying to educate them on the goals and like what's the right number. I think that might help them to understand how to start.
Okay, I think all of that is excellent, and especially what you initially said. Health literacy is, we don't take it for granted. You just don't. You don't say things like, okay, I want you to retrieve the memory, use the memory function on it, and they'll give you the average systolic and diastolic, and you can use the printout feature and bring it into me. Do not say things like that. They're not going to do it. So training is critical. Arpita, I think one of the things that you mentioned was bringing them in for a nurse visit and calibrating machines, etc. That's quite a bit. at your practice, that might be okay. For some of the smaller practices, that might be more difficult. So I would recommend a text message of a video that shows them how to do it. And I think I certainly believe this. I think Jackson Wright has said this. Everybody with hypertension should be doing home BP monitoring. Not necessarily every day, but at least on a regular basis, because it reminds them that they have a condition. It helps them manage things. It empowers them to seek better care as well. Okay. Anything else besides, Arpita mentioned all the wonderful things about training the patient. What else would you do to ensure success?
Bhaskar, again, I don't know that one set of recommendation fits all. I mean, so we have to individualize our approach to different patients. You did mention level of literacy and understanding and all that. I think that comes into play. I, I don't know what the correct answer is.
Yeah, it's not just that's a very good point. Not just literacy, but it's motivation as well. I mean, a lot of people with high blood pressure just are not motivated to do this. Sorry, Jim, you were going to say something. I missed it. You're muted.
Oh, yeah. Good morning, Dr. Rao. I just joined in. I'm in clinic right now. I just saw a patient, so yeah, I'll read the case.
Okay, don't worry about it for now. Okay.
The second thing I just wanted
Yeah.
to add up is to make sure the patient's actually getting coverage from the insurance for the machine, or like if they have difficulties like buying a blood pressure cuff or that. And some patients, they don't know which one is good. They start with a wrist one. We have to educate like and make sure like they are doing it in the right way, and financial assistance if needed for the blood pressure cuff.
Yeah, Arpita. So Sherry has pointed out, Dr. Bowen's pointed out, Cardio has a sheet on home BP monitoring, how to get a machine. They are covered by Medicaid. They also all have to meet a certain standard. Anything by the company Omron, not pushing any specific company here, but they all meet the standard. So the Omron Series 5 or whatever, which is like $39. So should be fairly straightforward, but thanks for raising the issue. Okay, I think if there are no more comments, I just wanted to throw out an anecdote here. We talked about low health literacy and overestimating. We also overestimate our patients' financial resources, which Arpita was getting at. I participated in an exercise in the UK as part of a panel discussion. This is a long time ago. And I was asked the question, they asked the panelists, can you estimate the 90th percentile of family income in the United Kingdom? And I said, I don't know. I guess it's kind of similar to the USA. I'm not sure. So my guess was £100,000 per year, which is about $130,000. The correct answer was 40,000, 40,000 pounds per year. So it just gives you an idea that we overestimate so many things about our patients, their ability to understand things, their ability to afford things, the ability to show up on time. We can't understand that because we don't come from those backgrounds quite often. Okay, Andy. Sorry, I think we can go on to Amanda.
Good morning, everyone. Just to kind of add on to that last conversation, I think it's also a good time to like bring in care managers and other folks that can help support patients as well. Just to kind of throw that comment out there. But good morning. Do some updates on our QI projects. Today we're going to talk about different runner control charts. So process measure, I think each of you have chosen one. Just kind of walk through what the data shows over time, how the data has supported your QI work. And that could be like helping inform decisions or PDSA testing. And then if you have any special cause variation on your chart, just kind of maybe briefly touching on that and maybe what caused that. So we can go to the next slide, Andy. David, we'll start with you. Fisher-Titus. David's going to talk to us about his process measure of percentage of patients with BP greater than 140/90 who received a follow-up within 1 month. So David, do you want to kind of talk us through your project and how this data has helped support your project over the course of the last year?
Sorry, I was having difficulty getting my audio to go off of mute. Good morning, everybody. So yeah, with the start of our project, we thought we had a decent a decent structure on how we managed our patients coming in for that 1 month checkup. But what we kind of found out through the beginning phase of this back in early March was that we had some gaps in how we were managing our patients. So what we put in process is the way that our blood pressures are taken, for one, to make sure that we had everybody consistently doing it the same. And in that situation, we found out that some folks were doing it over heavy clothing. They were not making sure they had the correct size of blood pressure cuff. So we got everybody standardized in the understanding on the importance and how we were going to be doing this, and also the process of making sure that when the patient leaves our room, they are identified as somebody who needs that 1 month follow-up. So as we went through this data, it helped to show us and give us the opportunity to look, especially for a month like June, is how are we managing the patients, and in that instance, why we had that sudden dip. And in that situation, what we found out, we had several people out on vacation, and we had other folks from other offices coming in, and we gave them the information on what we were doing, wasn't necessarily followed. And so that made a huge difference. And the data was able to show us that that was our reason for such a low percentage for that month. I believe we had about 5 out of our 7 folks that were gone for at least a week and a half. So as you can see, we jumped right back up in July. And, our process, and not only from the room and identifying the patient initially when they come in, to alerts in the chart, to identifying on the outside of the room that the patient is needs a BP check. And we also have a little heart that we put on there because we're using a dry erase magnet that we were using for some of our Kaizen boards. And we just would write on there, and somebody would just draw a little red heart, and it identified that that patient was a part of the study, and that we had to make sure we had that 1 month follow-up. And, we're seeing a much higher incidence of patients that are doing that and understanding why. And we also worked on our explanation on how our staff are explaining to patients why that 1 month is so important. And so we were able to use some of this data to incorporate the data into our explanations to patients on how this is important and what it's doing for our control of blood pressure, and making sure we're getting patients where they need to be so that they're healthier. And I think that's probably about it. Did I miss anything, Amanda?
No, I think it's just to kind of summarize, it sounds like you've done a lot of like standardizing your processes and workflows.
Yes.
But the only thing that I would kind of add is I think I remember when you had that dip, that 40% in June from the staff that was coming in to help out, you identified that, but then you were able to implement some additional training to make sure that,
Yes,
they were following the office protocol. So this data, I think, allowed you to be able to, be alert to that and provide that additional training.
and it also allows me to show the other managers that we do indeed see a change when folks float to other offices. And so we're able to use this to say, hey, this is identified as an issue. And the standardization is a little bit easier with this data because the managers do see it and recognize it. And so we're working on that for the other offices as well.
Yeah, great work. This is awesome to see. So you guys have done amazing work. Thank you, David. All right, Village of Healing. Amber, do you want to talk to us about your process measure percentage of patients with BP greater than 140/90 who also attended the follow-up?
Yes, good morning, all. Our focus was to reduce our patients with high blood pressure. We started with a general overview, making sure that we are all taking blood pressures the same way. So we kind of focused on like an orientation day. And then that was like phase 1, and we rolled that out. We also, in that process, learned that our vital sign machine has like a 3 average way that you can take the blood pressures if they're high. So we implemented that into our process. And our goal was to have our patients, if they had high blood pressure, 140 greater than 140/90, that they would schedule with the nurse to follow up in a repeat in 14 days or 2 weeks. And in the beginning, we had good outcomes. And then right about July, August, we lost both of our support staff at the same time. And so then it was just myself working the plan. So we can see that drop there. I admit that, having no support staff was very challenging. And then we quickly hired rehired mid-August, and we started to see it rise. Which also started with another orientation for our newer staff person. And we're starting to see that rise again in the September, October months. We've gotten great feedback from our processes. So with the nurse visit, the nurse and I worked very closely together to make sure that our patients are receiving kind of the same information across the board. So we set up a smart set. We use Epic. So we were able to work with our Epic technical team to set up like an actual documentation smart set that I myself, the provider, a women's health nurse practitioner, also we're using the same language, using the same order sets. And the nurse, when the patient does come in, there's different education that's provided. So that first nurse visit is talking about what a blood pressure is, like, so that the patient has information on the, systolic, diastolic, how to take their blood pressure. We try to make sure that they're getting blood pressure cuffs ordered. So we have that written into the smart set based off of Medicaid's, qualifications. And so during this process, we really standardized how we take our blood pressures, the language around when we're talking to our patients with around education with their high blood pressure. We talk about diet and exercise and the whole gamut. So it's really been a large project, but I feel like we've seen really great outcomes. Our patients have given us great feedback in a lot of ways to help us even just with the standard flow, like, hey, can you let me sit for a little bit? We have sound machines in the rooms now because some patients say like they can hear other patients talking through the walls. So we've gotten sound machines that's helped with relaxation in the rooms. A lot of our patients are super anxious when they come in. So we've implemented, we've taken their feedback and implemented it in this program as well in our pilot. And I really just I felt like we've mastered a lot of great things during this. And in my opinion, our graph kind of really flows with that. Like our outcomes, our interventions, we see great victories in that. So.
Yes, Amber, it's been very exciting to see all the work you guys have done. And you guys have really done great work in standardizing your follow-up and creating that education and really involving the patients in the education as well, and to make sure that you get their feedback. Talking about literacy during this talk, you guys have really done a great job at that. So thank you. All right. We can move on to East Liverpool. Hen, are you on to talk about, or Jim, I don't know who's going to talk about your process measure, percent of patients age 40 to 75 with that high ASCVD risk score greater than 10 who are prescribed a cholesterol lowering medication.
Yes, so I believe we already have discussed this graph. So just for everyone to know, so our QI project is we are prescribing prescribing cholesterol medications, be it statins or Repatha or anything related to that. And then we're tracking these patients according to their LDL levels and their follow-up visits. And then our prescribing from the clinic, and then they're refilled. So far, this graph tells us that in our clinic, we started low at 60 in terms of prescriptions, and then as the months went by, our prescribing ability, or the patients receiving these statin or cholesterol lowering medication prescription, has improved. And then if you notice, there's some dip right there, but then it went up again. So comparing from start to finish, so we are already hovering at our target level, which is between 75 to 85, which is which is our target. And so far, it's an ongoing thing. Our QI.
Yeah, great job. I think along the way, you guys have been able to use this data to really make a lot of tweaks to the workflow, and even made some changes with the way you were looking at data.
Yeah.
And so do you feel like that's been a benefit to sort of help guide some of those changes?
Yeah, absolutely. Because it gives us a feedback on, especially when they follow up, it gives us the feedback on repeating giving us a chance to repeat the lipid panel, and then making adjustments whenever appropriate. And so
great. Yeah, great
yeah.
work. Great
Okay, thank you.
Thank you.
Thank you.
All right. Next, we're going to hear from Arpitha from Metro Health to talk to us. This process measures percentage of patients with that high ASCVD risk score greater than 10 who were not on a statin originally, and then who scheduled that follow-up appointment so that she could continue to work with those patients.
Thank you, Amanda. So our project is similar to the East Liverpool project, but the difference is we do have two process measures here, and my focus was to start on statin to a patient with ASCVD risk over 10% who were not on statin. First process measure was to schedule the appointments for the patients who did not, who haven't seen in last 6 months to 12 months. And the second end goal is whether the patient is started on statin or not. So if you see the graph, since the project was started roughly around April 25th, 2025, and around that time, the score was only 35%, and the first few months it went very well, and then we had like a plateau. That's mainly like we had a lot of changes in our provider templates, where we couldn't get patients for follow-up because of change from telehealth to in-person slots, and a lot of scheduling timeline was almost like 3 to 4 months apart. So then we figured out the way of getting these patients who are also due for their preventative visits, and they're trying to call them and see if they are interested in getting the labs before the appointment. So we got everything taken care before the patient can follow up, and actually the numbers improved close to 100% at one point, and then now we are meeting our goal. Can you go to the next slide, please? So if you see in this, the last, the one in the highlighted is total number of patients who were meeting the criteria for like eligible for statin who are not on statin with their CVD score was 62 in 2024. And when we started the project, it was almost like 60, and now the numbers went down to 49. So definitely the process map and the QI is working. We still have some setbacks, but we are trying to like focus more like on patients scheduling follow-ups and getting their lipid panels done, and like following up every 3 months on them. Thank you, Amanda.
Thank you so much for sharing. It's been very exciting to see that standardization, and you created that new process, and starting at about 20%, and now you're up around 90% of those patients getting follow-up. That's incredible. So thank you for sharing your work with us.
Thank you.
All right. So just thinking about our next meeting and reporting out for that. So, as the project is coming to a close, we want to think about sustainability and what that might look like. So we've decided to focus on sustainability. And one question, we're going to provide you a worksheet after this call. And the one question that we would like for you guys to focus on is hardwiring the change. So you can see an example there, but how will we make it hard to do the wrong thing and easy to do the right thing? So reliance on that human memory. How do we standardize? You guys have talked a lot about standardizing today, which I think has been really helpful in your processes. So talking about how to standardize, documenting that standardization and those resources for new staff and that ongoing training would be something to consider. But this is just an example of an RN pharmacy collaboration that they found successful. They created that workflow and how they might automate those referrals to the clinic for patients with poorly controlled diabetics. So having a referral system in place and something that would in the EHR could be, a way to sustain. So a lot of different things that you guys kind of brought up today that could go here, but would love to hear from you next month about the sustainability efforts. All right. Andy, are you going to close this out?
Yes, I am. Thank you. So just a reminder, we have our cardio webinar later this month. We invite all of you to attend. There is a free credit of CME for attending, and you can register through the QR code or at cardio.org. And then same reminders, a post-clinic survey has been emailed to you. Please complete it by next Friday, the 13th. And just data reminders, you have 20 patients seen in January due tomorrow, and then your patients you see in February are due March 6th. And our next clinic will be March 5th, over overcoming barriers and sustainability. Thank you so much, and we'll see you next time.